So I figured that Jacques Kiladjian would appreciate the crowd being waked up since we went through a couple of tough and good talks. I'm glad he's made it all the way here from Paris, France, where he is clinical pharmacology director at the Paris Interferon University, and he's also a hematologist at the St. Louis Hospital. So he is going to speak to us about the future of interferon and MPNs. Thank you for coming, Dr. Kiladjian.
Thank you very much. Thank you, Dr. Camoriano. Thank you, Ruben, for your invitation to be part of this meeting. Thank you.
Yeah.
Doesn't work? I don't know. Can you hear me now? No? Okay, I use this one. Is it better? Okay. So I was just thanking John and Ruben for their kind invitation and Angie for the fantastic help in organizing this. It's the second time I'm here. We don't have such huge meetings of patients association in France, and we really miss that. And I can feel the energy, and I think this is the biggest reward for our work and push us to continue and show that it's not useless what we're doing. So the future of interferon. Really, I think the title was fair because now everything will change, I think. We enter a new period, at least in Europe, because as you can see on this slide, just a few days ago, the European Medicines Agency approved for the first time a formulation of interferon, the ROPEG interferon alpha 2B. The commercial name is Besremi. As you can see, the indication at the bottom, Besremi is indicated as monotherapy in adults for the treatment of PV without symptomatic splenomegaly. So I think this will really change the life of our patients in Europe because now we have this drug approved for the first time, although we use it almost for 40 years, as you know, and due to the work of Dr. Silver in particular. So this approval was based on the results of a phase 3 randomized study that was performed in Europe, the so-called PROUD PV study. And Heinz Gieslinger presented the 3-year results at the last ASH meeting a few weeks ago. And I will share with you the most important results of this study that compared hydroxyurea as reference treatment to this new formulation of interferon alpha, the ROPEG interferon alpha. This is really the same pharmacological principle. This is interferon alpha 2B, just it's a new formulation that allows the drug to be much more stable in the body, and it allows for only one injection under the skin every 2 weeks, and even once monthly in most of my patients now, after 1 year of treatment usually. So a very stable form. And this study, PROUD PV, was designed first to compare head-to-head ROPEG interferon to hydroxyurea, mostly as a first-line treatment for patients with polycythemia vera, with a 12-month endpoint that was to show that this interferon was not inferior to hydroxyurea to induce hematological response. And then patients, if they wanted, could switch to the so-called continuation PV, roll over to this, remaining on their treatment for a much longer follow-up, up to 5 years, hopefully. And now we are at 3.6 years of follow-up for these patients to assess the efficacy and the long-term safety of this treatment. You can see here the number of patients, 127 patients entered in each arm at the beginning of the study, 95 of the interferon and 76 of the hydroxyurea treated patients continued on continuation PV. So first, I'd like to share the toxicity of this drug because this is one of the main issues. Is interferon well tolerated or not? And you can see here that we were really pleased to see that indeed there was no big difference between the two drugs, although the safety profile was a bit different. You can see here that in hydroxyurea-treated patients, we had more hematological toxicity. The platelets were going lower, the leukocytes were going lower, more anemia were seen in patients who received hydroxyurea compared to interferon. On the other hand, we had some liver toxicity, an elevation of liver enzyme that was completely asymptomatic, but just a biological finding that was seen only in interferon-treated patients and virtually not in hydroxyurea-treated patients. So overall, let's say there was no difference between the two drugs in terms of tolerance. In terms of efficacy, this was spoiled earlier this morning by Dr. Silver, that you already saw that the complete hematological response, meaning normal counts, hematocrit below 45% without phlebotomy, normal leukocytes and normal platelets, was achieved in about 70% of patients after 3 years on interferon compared to 51% on hydroxyurea. And the change, the crossover between the two treatments occurs somewhere between 12 and 18 months of treatment. So again, you have to be patient if you start a treatment with interferon. The aim is not to achieve a complete response within few weeks, but to achieve much longer term endpoints that are, in our opinion, more important, like the change in the mutant allele burden, the change in the bone marrow histology, and blood counts may take a longer time to achieve the response. But overall, at the end, it's superior. The same if you include complete response, normalization of blood counts, and also improvement in disease burden that included the symptoms like pruritus, the spleen size, etc. When you combine both, again, you have a better response on interferon, 52% of patients compared to 37% of patients who achieve this combined response on the long term. And also the same for the molecular response, the diminution of the JAK2 mutation. You can see that again, after 12 to 18 months of treatment, we achieve around 70% of molecular response with interferon, although these continue to decline over time in patients receiving only hydroxyurea, down to 27%, for example, at 3 years, compared to 66% in interferon-treated patients. So these results prompted this approval in Europe, so we are really happy, so our patients will be able now to receive the drug on label and not off label as we used for many years. The second finding I would like to share with you is a study, an analysis we showed at the last European Hematology meeting in June that compared the efficacy and the tolerance of the drug in patients younger or older than 60 years. As you saw in many of the guidelines, often we see hydroxyurea as the reference, except in patients younger than blah, blah, blah. Assuming that maybe there's a leukomogenic difference between the two drugs, and also that interferon is poorly tolerated in patients, in older patients, suggesting that maybe we couldn't use this drug. So to see if this was true, we tested this, we analyzed the two groups of patients, younger than and older than 60 in this trial. And you can see that at 24 months, for example, here you see the results in patients older than 60 compared to younger than 60. And again, in blue, patients treated with interferon, in green, patients treated with hydroxyurea. And you see that even in this population of patients, there was a huge difference in terms of complete hematological response, in terms of hematological response plus improvement in the disease burden in these patients older than 60. The same in terms of maintaining this response, because it's nice to achieve the complete response at one time point, but the important point also is to maintain this over time. And you can see that in these patients older than 60, 37% of them maintain the complete response over time, compared to only less than 20% in hydroxyurea-treated patients. And the same also for the molecular response. More patients older than 60, 58% of them achieved a molecular response compared to 36% only in hydroxyurea-treated patients. So, and for the efficacy, it's clear that we are more efficient with interferon than hydroxyurea, even in patients older than 60. But the other point was the toxicity. And as you can see on this busy slide, in fact, there was no difference in terms of toxicity. And if we focus on the so-called adverse drug reactions, so adverse events that were due to the treatment, you can see that we observed 66% of such reports in patients treated with interferon compared to almost 90% in patients receiving hydroxyurea. And if we look at the serious adverse events that really required hospitalization, for example, or things like that, none in the interferon-treated patients older than 60 compared to 10% in hydroxyurea. So it's not worse maybe it's even less side effects in this population of patients older than 60. So I think this analysis provides a good evidence that this treatment can be given to any patients, regardless of age, as long as we consider that there's a clear indication for that. And we should not restrict ourselves, saying after 60, 65, this patient shouldn't receive interferon just because of his age. So another possible future of interferon, in my opinion, but I know that we don't agree with that with Dr. Silver, is that maybe we can have some treatment discontinuation. This comes indeed for our observation from our phase 2 study, PVN1 study, when we looked on the long term, after 5 years, at the patients who discontinued treatment, we were surprised to see that 38% of them stopped treatment because they achieved a good response. And the doctors progressively reduced the dose, tapered the dose, and at the end stopped and see what happened. And this was more than patients who stopped for toxicity, 27% of them. And what also is interesting, you can see here the curves. The orange curves is the discontinuation for toxicity that occur mostly during the first and the second year of treatment. If you don't have toxicity after 2 years, the probability to stop the drug because of an adverse event is very low. In contrast, you can see in blue the accumulation of patients stopping because they achieved complete response. So this was quite unexpected. And we looked to what happens to our patients after discontinuation of treatment. And we looked in the St. Louis Hospital database to see how many patients had received interferon, how many of them stopped, and what happened to them after that. And between 2000 and 2016, we found that 333 patients received interferon at any time during their disease for the treatment of their MPN. We took at least patients who received the drug at least for 3 months. 149 of them had stopped. You see that it was mostly PV and ET patients and few patients with myelofibrosis. Half of the patients had stopped for toxicity reasons, but again, although this is not written in any guideline, we are surprised to see that 1/3 of them had stopped treatment because they achieved this complete response with very low doses, and everybody agreed to stop and see what happens. The median time on treatment was 28 months. And at last follow-up, among these 149 patients who had discontinued the treatment, 109 were still in complete hematological response for a median duration of 42 months after discontinuation, including 46 of them who didn't receive any cytoreductive drug after stopping interferon, meaning that they remained in complete response without anything, just after interferon for a median time at that time that was 33 months. And now the first patients in whom we stopped reached 11 years without any treatment and normal counts after interferon. Interestingly, when we looked in multivariate analysis on the factors that had an influence on this probability of being in complete response without drug after treatment, the one that came as the most important was the mutant allele burden at time of discontinuation. You can see here on this graph that when your JAK2 mutation is 0, undetectable, when you stop interferon, the probability to remain in complete response without any drug is about 85, 90%. So very high. But it's not indispensable. For example, if your JAK2 allele burden at the end of treatment is 5%, you still have almost 60% chance to remain in complete response without treatment. Meaning that if you can reduce the mutant allele burden, at least that's my interpretation, if you can reduce the mutant allele burden to a very low level, even if you stop treatment, your body is able to control this residual disease and avoid the re-expansion of the mutant clone, maybe because you restored some immunity with the interferon treatment. We don't know, this is purely speculative. But even if you have still a small amount of JAK2 mutation detectable, you may remain in complete response without anything for a very long period of time. So this could be another good reason to try interferon, because no other drugs, to my knowledge, can induce such a high proportion of discontinuation without relapse of the disease on the long term. So it's maybe nice to try at least. Another possible future of interferon, of course, is to combine it with other drugs. And I know that several colleagues, and maybe some of you already are treated with the combination of interferon and ruxolitinib. We are testing this combination formally in a clinical study, which is performed in 2 parts, and I will show you the results of the first part that we presented at ASH 2 months ago. This study has a first part that tried different combination of dose of both drugs, because who knows if you need to give a high dose of ruxolitinib and a low dose of interferon or the opposite. So we have no idea, so we tried to test different combinations. And from this first part, we selected the 2 best ones, and that will be tested now, starting at the end of the month, in the second part of the study. So we selected 3 different doses of ruxolitinib, 3 different doses of pegylated interferon alpha that made theoretically 9 possible combinations. And we started with the lowest dose of both drugs, treated 3 patients. And if there was no toxicity, then there was a mathematical algorithm telling us which dose we should test next. 3 new patients, if nothing happens, etc., etc. So at the end, we had to test, as you can see, 6 combinations, and we reached the highest doses of both drugs. And none of these 18 patients developed any toxicity, at least on the first 45 days. So now we know that we will test these 2 different combinations for the second part of the study that is just starting now, with this time an efficacy endpoint. We test first the toxicity and the tolerability of the both drug combination, and now we will test on more patients, for a total of 42 patients, the efficacy. But of course, as doctors, even if it was not the objective of the first part, we wanted to see if we had already some efficacy. So I will share with you these results. You can see here the splenomegaly, the response in the spleen size, that was reduced by almost 50% after 3 months and remained stable in this first part of the study. We could confirm also the nice reduction of the JAK2 mutation. Here you can see the evolution in individual patients, and here the mean from 70% before treatment to 46% after 12 months of treatment. And we also, of course, try to make a lot of biological studies to better understand the impact of both drugs on the disease. And one of them, of course, is to study the evolution of the additional mutations. And you can see here, for example, one of my patients that received the lowest dose combination of both drugs. These patients had 5 mutations: JAK2, I6L1, DNMT3A, EZH2, and TET2 mutation. And you have in blue here the mutant allele burden before treatment. For example, it was 80% for the JAK2 mutation at baseline, and in red after 12 months of the combination. And we are pleased to see a nice reduction in the JAK2 mutant allele burden as expected, but also in the other mutations, including one that is no longer detectable after 12 months. So we have an efficacy not only on JAK2, but also on the other mutations. I won't bother you with that, but just show you that we also collect the samples to test and to dose the different cytokines for the inflammation you heard about this morning. And we will have, I hope, some results about these cytokines, because we see already 3 different profiles. Some of them don't change over time. Others diminish clearly over time, and others have a wide evolution on treatment. So maybe we will be able at the end to select some profile of this cytokine that may be predictive on the response or the toxicity of this drug. We are also studying the immune cells in these patients. As you know, interferon alpha is an immunostimulator, induces your lymphocytes to fight the disease. And this is also the explanation for some of the side effects. When this reaction is too strong, it develops some so-called autoimmunity against normal cells. So we are testing these immune cells at baseline. The study design is to start with 2 weeks of ruxolitinib. So we have a baseline without any drug. Another point after 2 weeks of ruxolitinib, and then we add interferon. So we will have also the effect of ruxolitinib alone and the combination, and we will see if this change and if this has some correlation, especially if we have discontinuations, as I mentioned earlier. And of course, we are studying the bone marrow biopsy of these patients at baseline and after 12 months of treatment. I forgot to mention, it was on the slide, but this study is only in patients with myelofibrosis, not in PV patients. And we already have some very nice responses, as you can see, for example, in these patients with a large decrease in cellularity and disappearance of fibrosis after 12 months. So we will have this data for a larger number of patients. And the last combination I wanted to mention today is maybe more surprising for you because it combines interferon alpha with a very, very old drug used for thousands of years in China that we rediscovered as Western doctors some decades ago, and which is now approved in hematological malignancies like acute promyelocytic leukemia, for example, that is arsenic. And to show you that we also have some compassion for living creatures other than human beings, we decided to treat mice first. Of course, we are a bit responsible because in these mice, we created the disease. We gave them your disease by introducing the JAK2 mutation. In these mice who develop a disease after about, let's say, 9 weeks or 10 weeks, polycythemia first, and the phenotype that evolves to fibrosis if you do nothing. So we treated these mice with interferon alone and the combination of interferon and arsenic. And what happens? You can see here the hematological response. This is the untreated mice with a very high leukocyte count, very high hematocrit. And in blue, you see the impact of interferon alone that already we shown earlier that it was efficient to treat these mice. And if you add arsenic, this is the orange line, you improve again, you have a deeper, better response in terms of leukocytosis. The hematocrit also is normalized very quickly without inducing a reduction in platelet counts. So it seems quite promising. In terms of molecular response, again, we have tested different drug combinations in mice, and we've never seen such a deep impact on molecular response. You can see here the mutant allele burden in granulocytes, untreated, interferon alone, and interferon plus arsenic. It goes very quickly down to 20% after 8 weeks of treatment only. The same if you look at the mutation in megakaryocytes and in red cells. And more importantly, when we study these mice, one way to see if you could eradicate the leukemic stem cell, let's say, the stem cell that has the mutation and produces the cell all along, to see if you could eradicate that, there's a technique that you treat your mice with the disease with your drug, you collect the bone marrow of these mice, and you transplant to another mouse that doesn't have a disease, and you look if your bone marrow in the second mice is able to reproduce the disease. If your mice develop the polycythemia, it means that in the bone marrow you still had leukemic stem cells that were able to reproduce the disease in the recipient. Okay, so here you have an example of secondary transplant of mice treated only, of bone marrow of mice treated only with interferon. So you treat your polycythemic mice with interferon, you collect its bone marrow and transplant to another. And you see that about 30%, 70% indeed of the mice will develop a polycythemia. So you could eradicate in about 30% of these primary mice the leukemic stem cell. With this combination of interferon and arsenic, and we did 4 independent experiments in about 12 mice. None of the secondary transplant developed the disease, suggesting that with the treatment, with the combination in the first mice, we were able to eliminate completely the disease-initiating cells. So this is really encouraging. And another way to test the impact of this drug is to treat your mice and stop treatment and see what happens, just like in our patients I showed you. We stop the treatment and see if they relapse or not. And you can see here that mice who received interferon alone, about 70% of them had a reinitiation of the disease after 9 weeks after discontinuation, compared to only 50% in the mice who received the combination of interferon and arsenic. So we treated mice. We hope that with this data, because we haven't observed any toxicity, because arsenic is used more than 15 years now in acute leukemia, so we have a good experience of the drug. We hope that we will try to start a pilot study in few patients who are refractory or resistant to all the drugs we have currently, are not eligible for transplantation, to see if we can reproduce these results that are really, really very encouraging. So to conclude about the future of interferon, although there still have some little clouds here and there, I think that the future of interferon is quite bright, and I would be happy to discuss that with you later. Thank you very much.